So dear students, we are still in the joint MCP of the wrist and hand complex, continuing from where we stopped. So I was just talking about how the FDP and FDS are oriented, and then how you can see in the structure that the annular ligaments are present, the deep transverse metacarpal ligaments are present, the annular pulleys are present, and the FDP, which is deeper, becomes superficial when the FDS tendons are splitting and then attaching to the middle phalanx, and the FTP will attach to the distal phalanx. So thereby the FTP will, that is flexor digitorum profundus, will what will be the action flexion of distal interphalangeal joint, and FDS will do flexion of proximal interphalangeal joint. Dorsal. So now we coming to the dorsal. We completed the polar aspect of the MCP joint. Dorsal to the deep transverse metacarpal ligament are sagittal bands on each side of the metacarpal head. So here you can see this is the dorsal aspect, posterior aspect, or dorsum of the hand. So you can see the long tendon, very strong long tendon, which is a tendon. This is the extensor digitorum communis extensor tendon. This is a sagittal view, side view. Here you can see this is MCP. Here you can see the volar plate. See the volar plate, how it is coming and attaching from this phalanx. That is the proximal phalanx, and then a continuation of the phalanx, and then coming and attaching to the base of the head of the metacarpal. Here you can see the annular pulleys, and the sagittal band is also attaching to the extensor tendon. So sagittal band attaching to the volar plate, also attaching to the extensor tendon. So dorsal to the deep transverse metacarpal ligament or sagittal bands on each side of the metacarpal head that connect each volar plate via the capsule, the deep transverse metacarpal ligament, and to the extensor tendon and the extensor expansion. So that means that already we have understood that the volar plate is attachment we have understood. Now here when it comes to dorsal part, the volar plate is also attaching to two more structures, which are the extensor digitorum communis tendon and the extensor expansion. So the sagittal band. So what is the biomechanical importance of sagittal band? The sagittal bands help stabilize the volar plates over the four metacarpal heads. That's all. Now coming to the collateral ligaments of the metacarpal carpophalangeal joint. The collateral ligaments of the metacarpal phalangeal joint, basically the collateral ligaments means they are always placed on the sides. So lateral collateral ligament, medial collateral, that is so we can otherwise here, because in the hand we can call it as radial and ulnar collateral ligament of the metacarpophalangeal joints are composed of two parts. We already saw that in the picture earlier, which is the collateral ligament proper, which is cord-like, and the accessory collateral ligament, which is the more secondary ligament, which is more volarly placed. So the collateral ligament is dorsally placed, and the accessory ligament is anteriorly or volarly palmarly placed. So the biomechanical aspect to remember is, we saw that in the figure before also, that the more dorsally located collateral ligament proper was lengthened 3 to 4 millimeter with MCP joint. So during MCP joint flexion, what will happen? We saw that during flexion, the proper ligament is lengthening to 3 to 4 millimeter, whereas the volarly placed accessory collateral ligament was shortening. So MCP flexion, ligament proper lengthening 3 to 4 millimeter. MCP flexion, the accessory collateral ligament shortening to 1 to 2 millimeter. This is what you have to remember. So normally what will happen when you do extension, when anyone does extension, what will happen opposite, conversely means oppositely, with the MCP joint hyperextension, the accessory portion was lengthened. Earlier during flexion, accessory portion was shortened. Now it is lengthened to 1 to 2 millimeter, and the what will happen to the ligament proper, which was lengthened during flexion, now it will become shortened by 3 to 4 millimeter. Now range of motion of MCP joint. Already we have gone through the the range of motion, that means the degree of freedom we have gone through. This is only to make you understand the difference in the MCP joint range of motion. See the figure. This figure clearly shows you how what with the biomechanical difference are. From here you can see this is a little finger, right? So little finger, see the MCP flexion. The flexion range is comparatively higher. This red portion is showing the range of motion. So see the angle. So here it is more acute, right? So even you go from the towards radially, from ulnarly, that is little finger to middle finger, ring finger to index finger, and forming a fist, you can see that the fist is the range of motion, MCP range of motion decreases when you go towards radially, increases when you come ulnarly. So this line clearly shows. So the middle finger, see the middle finger is in the straight line almost, and then how the range of motion is differing. So this figure is very important to understand that. So you understand that the MCP joint range of motion is not similar for all fingers. They are differing. The total range of motion available at the MP, that is a metacarpophalangeal joint, varies with each finger. Flexion extension increases to radially to ulnary. Ulnar increase from radial. Radial it is not that much. So increasing towards ulnarly. Increases radially to ulnarly. So from radial side to ulnarly, flexion bar extension increases with the index finger having approximately 90 degrees of MCP. So we can say that the index finger, which is radially placed, has 90 degree of MCP joint flexion, whereas the little finger has 110 degree. So 90 degree from the index finger to 110 degrees. So almost 20 degrees of freedom, degrees of range of motion increases from index finger to little finger. So little finger has 110 degrees. So this is mainly to why this is happening, or why, what is the benefit, biomechanical benefit is it increases in the gripping activity. So if you are holding something, that means that it will increase the grip. The range of passive hyperextension has been used as a measure of generalized body flexibility. The range of passive hypertension has been used as a measure of generalized body flexibility. The range of adduction is maximal in MP joint extension. So you see now, you all of you try to flex your MCP joint and try to spread your fingers. You cannot do that much. Try this. You cannot split your fingers, but open your hand. Mean hyperextension. Do you extend your MCP and try to split your hand? Wow, you can really split your hand. See, the fingers will go away from each to other. Now flex the finger and try to do. You can do, but not like when you are extending your MCP. See, these are the physiotherapist will understand more. This is of the biomechanical aspect. Now all of this will help you whenever you are treating a patient after any plastic surgery. And already I told you that very important that is. So MCP joint, I hope you understand the biomechanical aspects we have discussed. Don't forget this. We have to remember it. So, so I think we'll stop here, because in the next class we'll start the interphalangeal joint of the fingers. So MCP joint, we have successfully completed the MCP joint. I hope you submit an assignment on MCP joint, and next class we will start the interphalangeal joint. Thank you.